Okay, so we're going to start this conversation on chapter 31, where we continue with respiratory disorders, focus on ventilation. The primary gases of respiration are carbon dioxide and oxygen. We want to remove the CO2 from cellular respiration and from waste products throughout the body and exhale that through the respiratory system and take in oxygen from the atmosphere around us. And we can exchange these gases in the microvasculature around the alveoli and the alveolus structures of the lungs. If we're compromised with the exchange of gases, we could either be hypoxemic, where we're getting too little oxygen, or we can be hypercapnia, which is where we're going to have an excessive amounts of CO2 within the blood. Hypoxemia can result from inadequate oxygen in the air around us, a disorder of the respiratory system that compromises the movement of oxygen, dysfunction of the neurological system, where we assess the needs of the body as far as if we need oxygen to increase or change our respiration rate, alterations in the path the circulatory system will follow, or the function of the system itself. Mechanisms that can result in hypoxemia, hypoventilation, an impaired ability to exchange the gases, inadequate circulation of the blood through the capillaries around the lungs, and the mismatching of the ventilation and perfusion. So mismatch of having the oxygen present when we want to exchange it and CO2 in the lungs to exchange those gases out. Manifestations that we will see clinically with hypoxemia, if it's mild, there'll be a metabolic acidosis, the heart rate will increase, there'll be some constriction in the peripheral portions of the body, diaphoresis, sweating, changes in blood pressure where we have an increase to help train up. The system is going to be processing that it is inadequate amount of oxygenation, and so we will see the tissues kind of scream at the nervous system to increase the respiratory rate and the blood pressure, hoping to move that through faster, and then slight impairment of mental performance with this hypoxemia. If it lasts long enough, we're going to have chronic hypoxemia. We'll see some compensation start to occur, increased respiratory rate, some constriction in the pulmonary system, increased number of red blood cells. We're going to try to increase the carrying capacity of the red blood cells, as well as start to become a little cyanotic, or be a bluish tinge to the screen or to the skin, predominantly around like the mucous membranes around the mouth, the nose, that you'll see some of that cyanosis to be pertinent in those peripherals, like those fingertips and toes. Hypercapnia is when we're going to have an increased levels of CO2 or carbon dioxide. This can be caused by a hypoventilation, where we're not ventilating properly or fast enough, and a mismatch in the ventilation and the perfusion of the blood and gases inside of the lung. The effects that we're going to see with hypercapnia will be an imbalance in the acid base, a decreased pH or increased acidity, respiratory acidosis. We might see some changes in the kidney function as the kidneys are trying to compensate for the increased CO2 levels. We will be able to convert with bicarbonate the CO2 and kind of shift it over into the bicarbonate ions and the hydrogen ions, so that we can get rid of the hydrogen in the urine, which is another method to rid the body of CO2. Also, nervous system and cardiovascular function responses to the hypercapnia that we can see. On disorders of the pleura, we can have effusion or fluid accumulation in the pleural space, or that cavity around the lungs. It can be clear, a serous charge, more transexudate, where it's a little purulent. There can be chyle or a sanguineous or bloody tinged fluid. Hemothorax, we have blood in the thoracic cavity, pleuritis, chylothoracitis, atelectasis, and emphysema. A spontaneous pneumothorax occurs when air fills a pocket in the lung, and then we have a rupture in that surface. It can be traumatic, either a penetrating, bullet wound, stabbing, some kind of penetration into the lung cavity, or it can be a non-penetrating, so be a blow to that chest. Tension pneumothorax, where there's extreme changes or differences between the intrapleural pressure and that around in the environment. Causes of some of the lung inflation. This can be from accumulation of fluid, a pneumothorax, where there's a collapse of the lung, partial or full. Collapse of a segment of the lung is one of the lobes we can see, like in the upper, the middle lobes, or the inferior lobes, the right and left lung. Some characteristics that we see with pleural pain typically has an abrupt, quick onset, usually unilateral to the localized, again, to that lower part of the lung field. We might see a referred pain up to the shoulders. It's made worse by movement of the chest, breathing, turning, twisting. The tidal volumes are kept small. Remember that tidal volume is that normal easy breathing. So when there's this pain, we're not going to, fully inhale or exhale. We're going to limit that gas exchange or that air exchange to minimize the movement in the thoracic cavity. The breathing can become more rapid, and then we can see some reflex splinting of the chest that may occur with that pleural pain. Pleural effusion is accumulation of fluid in that pleural cavity. It can be a transudate, an exudate, a purulent drainage, pile, or blood. So we can have different types of fluid that are filling that space around that lung and that serous membrane. Diagnosing, we're going to use chest radiographs or x-rays, ultrasound, CTs to diagnose and to image that lung fluid. Treatments are going to be directed at the cause of the disorder. So if it's maybe a thoracocentesis, we're going to puncture it to sample that fluid out, and injections of some sclerosing agents, a drainage tube to allow that fluid to come out. With atelectasis, we have an incomplete expansion of the lung or a part of the lung, typically caused by an obstruction. If there's compression on the lung, maybe from the pleural effusion, that fluid building up in that cavity and kind of restricting that lung's ability to expand. Some of the increased recoil that we can see due to a decrease or insufficient amount of surfactant. So we can have a primary type of atelectasis where it happens when you're at birth, so it can be congenital. A secondary atelectasis that develops in the neonatal period or later in life. So it can be spontaneous or build over time with increased friction in that lung space. All right, so a checkpoint question. So which of the following is a disorder caused by an abnormal accumulation of fluid in the pleural space? And that is going to be pleural effusion. That's where that fluid, depending on what kind of fluid it is, like in the transudate, exudate, pile, or different type of fluid, bloody fluid or sputum, that fills in that serous membrane around the lung tissue. Physiology of some of the airway diseases, it can be in upper or lower respiratory tract. That larynx is going to be that dividing marker. Trachea and major bronchi. We're going to be the upper respiratory tract. The bronchi and the alveoli are going to be part of the lower respiratory tract. Creation of a negative pressure within the lung field, and then some of the effects that we've talked about with CO2 and pH levels with a respiratory acidosis or alkalosis. We can have inflammatory mediators that are going to be responsible and influence the disease process in the lung field. And we'll see an increased airway responsiveness, bronchospasms, increased mucus production, and accumulation of mucus in those airways with some of these airway diseases as a response to inflammation and mediation of microbes moving further down into the lung fields or into the lung tissue. The bronchial smooth muscle, this is important to change the diameter of the lumen of the vessels. The presence or absence of secretions can change the ability to breathe or patency. Bronchial smooth muscle is going to be innervated by the autonomics So we'll see constriction of the airways with vagal control, and then we'll see the sympathetic stimulation will cause a bronchodilation. So a lot of times when we see steroids utilized for breathing conditions like asthma, those inhaled steroids are going to cause a bronchodilation or expansion of the smooth muscle here in the lungs, allowing for easier breathing. So those are those beta-2 adrenergic receptors. Some factors that can contribute to a asthma attack developing could be exposure to allergens, respiratory tract infections, exercise-induced asthma attacks, drugs exposure, hormonal changes, emotional upsets. So extreme nervous system fluctuations can cause increased risk of asthma attacks. Again, pollutants and GERD all can contribute to the development of these attacks. Now, factors that lead to the development of asthma, they can be genetic. So we can have some atopy, either early versus the late phase, acknowledgement or diagnosis of asthma, environmental induced asthma from viruses, allergens, and occupational exposure. If you're working in conditions with sawdust or silicon, powders, refineries, coal mines, things like that, those occupational exposures, depending on the size of the particulate, specific masking might be helpful if it has the ability to remove those size particulates that you're working with. Asthma is classified by its severity, whether it's a mild intermittent, where it can start and stop, mild persistent, moderate, and severe persistent asthma, and different medications, inhaled corticosteroids, mucus reducing medications, might be a slew of different approaches to dealing with the asthma, depending on what is the issue with the patient. All right, so checkpoint question 2, which of the following has not been implicated in the development of asthma? And the answer here is the diet, with the caveat that some inflammatory diets that are high in refined grains and sugar are pro-inflammatory and have been shown to play at least a factor in the symptomatology, the exacerbations, and to the levels of the asthma attacks that the patient will experience. So we're going to keep that in mind if you're looking to help promote reduction in this with your patients. All right, so chronic obstructive types of diseases are the COPDs. There's inflammation and fibrotic tissue being laid down in the bronchial walls. There can be hypertrophy of the submucosal glands, increase in secretions of the mucous glands, loss of elasticity within the lung fibers, which can wreak havoc on being able to recoil that lung tissue and exhale that air out, increasing the residual volume or the amount that is being trapped. This can increase the risk of collapsing of the lungs and infections in the lung, COPDs. The alveolar tissue changes that we're going to see is a decrease in the surface area for those gases to be exchanged. Some of the common causes or types of COPD, we have chronic bronchitis, emphysema, bronchiectasis, and cystic fibrosis. The first type of chronic bronchitis is emphysema. We have enlargement or hyperinflation of the air spaces in the alveolar tissue. We have destruction of the septum that separates one alveolus to the next. And we have two types, the more centriacinar and the panacinar versions of emphysema. We see hyperinflation of the lung tissue and pink perfusion of their mucous membranes because they are still able to inhale and breathe the oxygen in. It's the exhalation portion that they struggle with, and so it's like breathing in normally and then trying to exhale through a straw. With the chronic bronchitis, we have obstruction within the smaller airways, and we have contrast here. We have the cyanotic type of COPD with the chronic obstructive bronchitis that we don't see with emphysema. With emphysema, we have typically a history of smoking. Typically, they're the primary smoker. Often, it can also be a possibility of it being a secondhand smoke exposure. Age onset with emphysema is within the 4th and 5th decade. Very dramatic barrel chest shaped. There's weight loss. There's a decrease in the breath sounds observed clinically. Normal blood gases are found until much late within the disease's progression. And so again, we have that pink perfusion, and so we call these ones the pink the pink puffers, as they have normal perfusion of the tissue. Again, that's with the exhalation and the removal of that CO2 that we have the trouble with. Cor pulmonale in very advanced cases, and it's a very slow progression, a very debilitating disease of suffocating the patient. Chronic bronchitis, typically, again, there's a history of smoking. The onset of this disease and conditions a little bit earlier. Let me see the barrel-shaped chest. There's shortness of breath is an early on symptom. A lot of sputum and discharge of fluid and bronchi can be present. Stark contrast as with this condition that these patients are going to be more cyanotic and bluish tinged in the mucous membranes than emphysema, even though both conditions fall within that COPD category. In a very dramatic cyanosis observed clinically, hypercapnia and hypoxemia may be present with this one because they're not able to inhale and to draw in the oxygenation that they're going to need. Frequent cor pulmonale, right-sided heart failure associated with this type of COPD, and polycythemia, we see an increase in those red blood cells as that body is trying to compensate and adapt to the struggling, metabolism throughout the body due to that low oxygenation. A lot more life-threatening episodes and exacerbations of chronic bronchitis versus emphysema. Bronchiectasis, this is a permanent dilation of the bronchi and the bronchioles. It's typically secondary to an ongoing infection or an obstruction within the lung. Some of the symptoms that we'll see: atelectasis, lung failure, obstruction within the airways, a diffuse inflammation within the bronchial tissue, recurrent chronic infections, coughing, very productive, sputum, very purulent and stinky smelling, and it can have some blood tinge to it and some hemoptysis in there as well. Weight loss and anemia are pretty common with this type of COPD. Cystic fibrosis, this is a genetic condition. It involves the fluid secretions within the exocrine glands and affects the epithelial lining of the respiratory tract, the GI tract, and the reproductive tracts. It's a single gene mutation in the 7th chromosome that encodes for the cystic fibrosis transmembrane regulator, or the CFTR gene, affecting chloride levels within epithelial tissue. Symptoms of cystic fibrosis or with this is some pancreatic exocrine component deficiency, so we don't see a lot of effects on the hormonal or the endocrine side of the pancreas, but we see the deficiencies on the exocrine side, inflammation within the pancreas, sodium chloride level fluctuations, and excessive salt within the sweat, nasal polyps, sinus infections, and stone formation within the gallbladder and pancreatic ducts. The diffuse interstitial lung disorders. This is a very diverse group of disorders that are due to very chronic exposure to dust particles that creates fibrotic or scar tissue changes within the interstitium or the interalveolar septum, again, the spaces between those alveolus within the lung. So some of the common types are sarcoidosis, occupational lung diseases, exposures again, to particulates within the work arena, hypersensitivity, pneumonitis, and lung diseases caused by toxic exposures. The occupational lung diseases fall into the pneumoconiosis. These ones are inhalation of inorganic dust and particulates like silicon, coal mines, you get asbestos, dust particles that are inorganic and non-carbon based. Hypersensitivity diseases, these are inhalation of organic dust and some occupational antigens, kind of depends on the exposure category they'll fall into. Bistanosis, associated with cotton workers. So we have fibers that create inflammation and hypersensitivity within the lung tissue. Pulmonary embolisms. These are bloodborne substances that get lodged and block the circulation in the pulmonary artery or obstruct the flow to the lung. So the types, very common one is from the deep vein thrombosis, from clot formations forming in the veins in the lower extremities and then dislodging and moving through the vasculature up into the lungs to smaller vessels. Fat mobilized from the bone marrow after a fracture of a long bone. Amniotic fluid that enters into the mom's circulation during exposure during the birth process or pregnancy. This is another type of pulmonary embolism. Hypertension within the lungs. Signs and symptoms that we'll see here is some difficulty breathing, some fatigue and tiredness, peripheral edema, ascites, and some truncal swelling, and then signs of that right-sided heart failure, that cor pulmonale. So this is a disorder that's characterized by an increase in the blood pressure within the pulmonary's blood circulation, or the pulmonary arterial blood supply system. The cor pulmonale is a right heart failure from a lung disorder or a long-standing primary or secondary pulmonary hypertension. So it involves hypertrophy of the right ventricle. Symptoms we see are those of the lung disorder that led to the cor pulmonale, as well as the symptoms of that right-sided heart failure. ARDS, or acute respiratory distress syndrome. So the number of conditions that can lead to this, they all produce a pathological change in the lung tissue, causing a very diffuse epithelial tissue damage and increased membrane permeability between the alveoli and the capillaries. So instead of having smaller particles being able to diffuse, we start to see other molecules that should not be permeating across that membrane start to create an immune response there. So some common causes are aspirations of gastric contents, stomach acid, with GERD or food, major trauma with or without the fat emboli, sepsis due to another type of infection, whether it's within the lungs or not in the lungs, acute pancreatitis, blood disorders, some different metabolic conditions, and then reactions to prescription and non-prescription drugs and exposure to toxins all lead to this respiratory distress syndrome. Now, if it leads to failure, we'll have an impaired ventilation, so upper respiratory tract obstruction, paralysis of the breathing muscles, the diaphragm or the intercostal muscles, or a chest wall injury. There's going to be impaired, matching of that ventilation perfusion, that timing when we have those gases on either side of those alveoli and our actions with ventilation and the inhalation and exhalation. there's an impaired diffusion across that membrane, leading to pulmonary edema and the respiratory distress syndrome. So treating this pulmonary failure, so it's going to be all of our treatments and guidance are going to be trying to maintain adequate gas exchange, so improving that ventilation perfusion, establishing that airway, allowing for air to move in and out of the lungs, bronchodilating medications, antibiotics if there's a bacterial infection, and ensure that there's adequate amounts of oxygen through an oxygen tank or oxygen therapy to increase the amount of oxygen getting to the red blood cells and then thusly to circulation. All right, question 3. Checkpoint question 3. So which of the following has been implicated as a causative agent for right-sided ventricular failure? And that's cor pulmonale. And cor pulmonale will result in that right ventricular failure due to the increased workload from that pulmonary hypertension or pulmonary disorder.